Hello, this is Amy Toone, and I'm recording the examination of the blood vessels. It is chapter 15 in your text. When you notice the blood vessels, you have to look at the heart and look at the circulation in the heart. Remember your heart valves. And this picture brings out that you really need to look at the subclavian artery on both sides, and because this is where you're going to get some of your pathology. Remember, you've got your carotid going up to your neck, and how carotid is different than the jugular is. On the carotid, you're going to see a pulsation going up on the artery, and when you get to the jugular veins, you do not often see the pulsation. So let's start with the physical exam. You're going to look at and palpate arterial pulses and distant extremities. You're going to look for the characteristics of rate, rhythm, contour, and amplitude. When you're doing the radial pulse, you're going to be on the thumb side of the wrist, and you want to look for, auscultate the carotids, abdominal aorta, which is midline, the renal, which is midline, but you're going to go up from your umbilicus. You're going to go up 2 stethoscope covers and over 1 for the renal. For the iliac, you're going to go down from the umbilicus 1 stethoscope cover and over 2. And for the femoral and arteries, femoral arteries are going to be in the groin, and so you'll need to auscultate all of these major vessels. This picture is just to remind you of what are the names of the vessels, because you'll need to know them and know where to get these pulses, like the popliteal, where's the dorsal pedalis, where's the posterior tibial pulse, etc. You'll need to know the names. Blood vessels, they measure the pressure in both the arms. You're going to look at the seated position, and then for patients at risk for orthostatic hypotension, the elderly, people with CAD, people on some types of medication, you're going to do standing blood pressures and look for a 10% drop in the systolic or a 5% drop in the diastolic in order to be defined as orthostatic hypertension. For a jugular vein, you're going to have the patient reclining at 45 degrees, and you're going to look for the pulsation, and there's a picture of this later on in the PowerPoint. Blood vessels, you need to inspect the extremity for sufficiency of arteries and veins, and look at the color, skin temperature, nail changes, any presence of hair or lack thereof, because that's going to let you know that there might be problems in the arteries. Vascular atrophy, edema or swelling, and varicose veins. Just want to remind you that there are some differences in the veins between races, and black people have more vein valves than white people, and therefore they're less likely to have problems with varicose veins because they have more valves, which keeps the blood returning to the heart with each valve. And so that's why black people do not have as much varicose veins as white people. The other people have a lot of problems with varicose veins, although this isn't due to skin color, but the Jewish people. And on the blood vessels, be sure to palpate the extremities for the warmth. To palpate for warmth in extremities, the best way to do that is to put the dorsal side of your hand on each leg or each arm and leave it there until it accommodates, or you cannot tell a difference in temperature between your hand, the back of your hand, and the patient's skin. Then switch hands to the side suddenly. And when you do that, if you notice just an instant difference in temperature, That's a difference in the warmth. And so you're going to look at the arteries and the veins of the cooler leg versus the hotter leg. And this is when you're looking for like peripheral vascular disease, peripheral arterial disease. And if there is any erythema or like a phlebitis, you'll also notice a difference in warmth, but the area with the phlebitis or the infection will be a little warmer. You want to look at the pulse quality. That is 1+ to 4+. And however millimeters you press down, 1+ would be 2 millimeters down, 2+, 4 millimeters down. It's always double. 3+ is 6 millimeters down, 4+ is 8 millimeters down. That's what you're looking for to see if there's any kind, how far you have to press for the pitting edema. So let's review a little bit of anatomy and physiology. Once the blood leaves the heart, the blood flows through two circulatory systems, the pulmonic and the systemic. Arteries are tougher and more tensile and less distensible than veins. Veins are less sturdy and more passive. They contain valves to keep the blood flowing in one direction, and only one direction. And as I mentioned, black people have more valves than other races in general. In blood volume, if it increases significantly, the veins can expand and react as a repository for extra blood. An example of that would be pregnancy, when you have up to 25% more blood. So you see here a picture between the pulmonic and the systemic circulation. And you realize there's a couple of things that really goes through the liver. Because you're going to look at the liver, because if you have right-sided heart failure, the blood will back up into the liver. And this is why we do the hepatojugular reflex. If you have left-sided heart failure, it's going to back up into the lungs. And this is why you're going to look at the left lung, particularly in the lower lobe, where you're going to have some consolidation of fluids, or rales or bronchi is what you would hear. Realize that the artery is much thicker. It's got a thicker endothelium than a vein does. And it is able to handle more pressure. And you notice that the artery doesn't have the valves as the vein does, and that's just to prevent backup in the vein. Make sure all the venous blood gets up to the heart, and from the heart go to the lungs for oxygenation. Arterial pulse and pressure are sometimes visible. Arterial pulses are the result of ventricular systole. It produces a pressure wave throughout the arterial system. It takes barely 2 seconds, or actually 0.2 seconds, for the impact of this wave to be felt on the dorsopedalis artery. So it's very hard to tell if you're on the upstroke or the downstroke of it. But it takes more than 2 seconds for a red blood cell to travel the same distance. So you realize that the blood will pulse very quickly in the arteries, but sometimes the red blood cells lag behind that pulsation. The following variables contribute to the characteristic of the pulses. The volume of blood are called the stroke volume. And the stroke volume is how much volume you have, and then the strength of the volume is going to tell you how good is the pump. The density of the aorta and large arteries, viscosity of the blood, and peripheral arterial resistance, meaning on peripheral arterial resistance, it's just resistance of all the peripheries for the blood being pumped out of the heart. And some of the medications that you give are going to decrease peripheral arterial resistance by working in the arteries or in the veins. Actually, it's usually the veins. But you want to know what that resistance is, because to control blood pressure, sometimes you have to decrease the arterial resistance. You have to control the volume, in the blood itself, and that's why Lasix and some water pills are given, is to decrease that volume of blood ejected, or in other words, decrease the stroke volume. The usual pulse. When you feel the pulse, most people feel the pulse when it bumps up, and that's at the end of systole. The activity of the right side of our heart is transmitted back through the jugular veins as a pulse, and it has 5 identifiable parts, 3 peaks and 2 descending slopes, but most people just know the top of the peak. Infants and kids, cutting the umbilical cord necessitates breathing, and respiration's onset expands the lungs, and if this cord doesn't fall off in a normal time, you're going to think that they might have some immune issues, because that would be the lymph system that would, for some reason, not be dropping that cord off. You can have pulmonary resistance will drop, and systematic resistance increases, which closes your ductus arteriosus in the first 12 to 14 hours of life. The foraminal valley closes after pressure shift in the heart from fetal circulation to, once the lungs start going, to normal circulations within the baby. Pregnant women, blood pressure decreases, and this is due to systemic vascular resistance decreasing. And peripheral vasculation occurs, and this causes enlarging uterus. The enlarging uterus causes compression of the vena cava and impaired venous return. And so this is why you don't want really pregnant women in their last trimester lying on their back. It can cause some hypotension, dependent edema. It's better for them to lie on their sides. Varicosities in the legs and vulva, and this is all due to compression of the venous return, and hemorrhoids. Older adults, the arteries calcify, arterial walls lose their elasticity, and vasomotor tone, and superficial vessels become more prominent, which will lead to more phlebitis or more varicose veins. And there's an increase in peripheral vascular resistance that elevates the blood pressure. And this increase in peripheral vascular resistance is something that gradually happens over time, and that's due to the vessel walls of the arteries calcifying, and sometimes it's due to a smaller lumina of the artery itself, or the veins itself. It's usually the arteries, because the veins don't tend to calcify as much. So, what do we need to review in the related history? You want to ask about leg cramps, their onset, duration, character. By character, are they relieved with movement or are they worsened with movement? You also want to know, do they happen while there's exercise? Does that cause the leg cramps? You want to find out if they're nocturnal. And you want to find out if these leg cramps also have any kind of other symptoms, such as tingling in the toes, pain, and then if they notice any color distortions of their feet or of their hands. You want to find out if there's any continuous burning at the toes, and with this you're wondering about peripheral neuropathy, pain in the thighs or the buttocks, and this can be from the L1 to L4 area. And S2 can be pain in the buttocks also, L5 to S2. You want to notice if there's any skin changes, if there's any kind of limping, because limping is going to cause leg cramps over time. It's guaranteed every time. And it also lets you know, is there any scoliosis or anything else that might be musculoskeletal in origin versus vascular in origin in the legs. Anytime you've got any kind of distortion of the musculoskeletal system, you always examine the joint above and the joint below to know what's going on with the rest of the leg. How is it compensating? And you want to find out if they're awakening at night with leg pain and cramps. And you want to find out, is the cramps in the gastrocnemius muscle? Is it in the anterior tibial area? Where is it? Where is the pain? Is it in the foot itself? On ankles, you can have swollen ankles, and if they have any present illness on an ankle, you want to find out, did they evert or invert the ankle when they injured it? Meaning, did they roll out or laterally, or did they roll in, invert? And that would be a medial difference. And why you really care is if you invert the injury or roll interior or medial, you're more likely to tear ligaments. But if you roll outward towards the lateral side, you're more likely to have a sprain. You want to find out any related circumstances, associated symptoms with the ankle, swollen ankles. Is it painful to touch? Can you have full range of motion of that ankle? Or is it just swollen? That's all it is just swollen ankle. You want to find out any treatment they have attempted. Have they put ice on it? Have they rested it? Have they elevated it? And any medications. Are they taking any kind of acetaminophen or any kind of NSAIDs for the pain, or is it something that requires an opioid? Past medical history. You want to find out about cardiac surgery or hospitalization, any acute rheumatic fever, and if they had any unexplained fever as a child, if they had a history of swelling joints or vasculitis. In vasculitis, one of the things that you can ask about is if they ever had Kawasaki disease, or if they ever had a tongue that was real red that they gave an aspirin for. And if they had any chronic illnesses, because any kind of chronic illnesses, particularly in the lungs, is actually going to affect the vascular system. The other chronic illness could be any kind of problems in the liver, because that's going to affect the vascular system. Any chronic problems in the gut will also affect the vascular system, because that's where you get a lot of absorption of the blood. Family history, look for hypertension, dyslipidemia, diabetes, heart trouble, any thrombus, peripheral arterial disease, and any peripheral vascular disease, any history of aortic aneurysm, and any ages at time of illness or death of the family. And why you worry about that is if there's an early cardiac death, you have to think about the vessels, and you want to make sure that there's no aneurysms anywhere in the vessels. Where there's going to be an aneurysm is where the pressure is the most, right at the root of the aorta. That's where your pressure is the highest in the aorta, and your second highest pressure is going to be in your descending aorta. And that's why you look for abdominal aortic aneurysms. Personal and social history, look for employment. If they're using tobacco use, because this causes vasoconstriction, their nutritional status, their usual diet, weight, exercise, use of alcohol, and the use of any kind of recreational drugs. The things that really affect the vascular system on recreational drugs is cocaine is one of the worst. Also heroin, just because it has such acute vasoconstriction. On infants and children, look for a history of hemophilia, renal disease, coarctation of the aorta, and any leg pains during exercise. You want to know if they do have leg pains during exercise. How far into the exercise does it happen? Does it happen all the time, or is it something that's intermittent? And this is an example. If it's some new exercise that they don't normally do, like a lot of squats, they're going to have a lot of problems and leg pains just from the muscular differences. But if they do not have leg pains normally, and they normally do squats, you're going to really worry about more of a claudication issue. Pregnant women, look at the blood pressure, look at the pre-pregnancy levels. Elevations during pregnancy shouldn't be any more than 10%. Associated symptoms and signs. On the legs, look for edema, varicosities, and pain and discomfort. Okay, I'm sorry I didn't pause that correctly. On older adults, you want to look for leg edema, any interference with activities of daily living, the ability of the family and patient to cope with the condition. And one of the things is pedal edema, how tight are the socks. You want to ask about any kind of claudication. Areas involved, unilateral or bilateral, any kind of distance one can walk before an onset sensation or length of time required for relief, and any medications they use for relief of the leg edema. Are they taking any kind of, quote, water pills is what they're saying, but are they taking any Lasix, any furosemide? Second, are they having to take any extra calcium pills? What are they having to take for all these leg pains and edema? All right, so what do we want to do? We want to observe and palpate the pulses. It's best to do this bilaterally, so put one hand on each side. Inspect the veins, measure the blood pressure. You're going to palpate these pulses, and you'll need to know where these pulses are, and they're outlined in your book. And then you want to palpate for arterial characteristics, any rate, rhythm, any kind of pulse, contour, amplitude, or the force of it. If it's symmetrical bilaterally, any obstructions or variations that you're noticing from either bilaterally or the upper extremities and lower extremities. And you're going to go ahead and rate them on a 0, 1 to 4, and they're listed here. 2 is what is average. Arterial arteries, you're going to auscultate over arteries for bruits, temporal, carotid, subclavian, the renal arteries. And you have a good picture of that in your book, so you can discover where they're at. So here we're listening over the carotid artery with the bell for bruits. A bruit will be a muffled sound, and it's just a sound that's instead of what you'd normally hear is a crisper sound, where you hear the blood go through just, but it's a real muffled, prolonged sound. Bruit types, realize there's radiation of all the murmurs. The aortic will radiate up to the carotids, the aortic valve. And notice this during the cardiac examination and see if there's any obstructive arterial disease. And on your assessment for peripheral arterial disease, realize our arteries are in any location become stenotic and are narrowed. And these will have diminished circulation in the tissues, will lead to signs and symptoms that are related to either the site, the degree of stenosis, the ability of collateral channels to compensate, or the rapidity of which the problems develop. The 3 P's of occlusion are pain, pallor, and pulselessness. Pain always comes first, then pallor, then pulselessness is the last one. Assessment of peripheral arterial disease, pain that results in muscle ischemia is referred to as claudication. It's a dull ache, It has muscle fatigue and cramps, and it usually appears during sustained exercise, such as walking a distance or climbing several flights of stairs. Has few minutes of rest will ordinarily relieve it. It occurs again with the same amount of activity, and continued activity will worsen the pain with claudication. And as you're assessing for peripheral arterial disease, distinguish the characteristics of the pain and look at these identified things. What do you really want to know about the skin or loss of hair in the legs? Ask them if they shave, or is that a natural loss of hair, because that is a sign of peripheral arterial disease in both male and female. You're going to see if there's any superficial veins that tend to be collapsed, and you realize that when you put your hands down and just dangle your hands, that you will notice that you've got that you have veins that distend. When you raise your hand above your head, those same veins should collapse, and that is normal. So here we're doing the pulses, and we're doing the carotid, the brachial, the radial, and the popliteal. I'm sorry, D is the femoral, fempop, and the posterior number E is the popliteal, and F is the dorsopedalis, and the posterior tibialis is G. And how I find the posterior tibialis is I grab the Achilles and just lean my fingers forward right at the ankle level, and I always find it. One thing if you look at the picture F on the dorsopedalis, if you draw two lines down the foot, dividing the anterior foot into three sections, you're going to find that you'll be able to find the pulse along the first bump closer towards the ankle on the lateral side, and on the medial side you're going to go closer to the toe where this is pictured, and you also find the dorsopedalis pulse. So blood pressure, here's your normals, and there's differences to ages, and you just need to have a chart to know what would be the normal blood pressure for each age group. And the ones you look at are 1-year-old, 5-year-old, 10 and 15. Anytime after 10 it tends, or 100 pounds, it tends to go to adults, but definitely by 15 years old it's an adult blood pressure. You want to know the diastolic and the pulse pressures, the difference between the systolic and the diastolic. So the pulse pressure is usually 40. And if this begins to get higher, you know that you have atrial insufficiency in the heart. So that means if it's more than 40 and the pulse pressure, they say, is wider between systolic and diastolic, look for atrial insufficiency in the heart, like PAT, atrial fib, that kind of thing. Another example of atrial insufficiency is if you had a high level in the atrium infarct. That would also cause a wider pulse pressure. Peripheral veins, the veins are the blue ones, and the veins are returning everything back to the heart. Realize there's a jugular vein pressure, and the jugular pulse can only be visualized, it cannot be palpated. And that's how you differentiate that between the jugular vein and the carotid. How I find the jugular vein the easiest is I go on the clavicle, go in about 2 inches, and then run up your neck, go up the neck. And I didn't say that I'm on the most lateral part of the clavicle. And when I go up the neck, you're going to see a flush on the jugular vein. Makes it easy to find. Conditions that make the examination more difficult: severe right heart failure, tricuspid insufficiency, constrictive pericarditis, and cardiac tamponade. Severe volume depletion. Obesity or overlaying adipose tissue obscures the jugular vein pulsations. So this is how you're going to look. For jugular venous pressure, you have to be at a 45-degree angle, and you're going to be looking at, when you push on the liver, how much up is that going from your internal jugular vein? How high does this pulsation increase? And in class, I will show you an easier way to measure this, but this is the way your book has it. So you're measuring the jugular venous pressure by having one ruler flat and one ruler just making sure you got a 90-degree angle, and then you're going to look to see where it pulsates with transcendental light. Hepatojugular reflex, it suggests that the hepatojugular reflex is a sign of right-sided heart failure. It often goes with it, but it doesn't suggest that you have it all the time. As patients have elevation in the jugular vein pulse with this maneuver, whenever you push down on the liver, there's going to be an elevation in the jugular vein pulse. And exaggerated when this is exaggerated or greater than 1 inch whenever the heart failure is present. So evaluations of the hand veins, useful in the absence of a thrombus or arterial venous fistula in that arm, or the absence of a superior vena cava syndrome. So, like I said before, just drop your hand. You should see your veins engorge. Raise your hand over your head, and those same veins should collapse. You also can assess for venous obstruction, and this is an acute process that results from injury or external compression or thrombophlebitis. In the affected area, pain occurs simultaneous with swelling, tenderness, engorgement of superficial vessels, and erythema or cyanosis. Peripheral veins are assessed for venous obstruction and insufficiency with thrombus or the Holman sign. The calf pain for passive dorsiflexion of the foot. And for edema, look for grading 1+ through 4+. And then, and remember edema, whatever the number is, 1+, that would be 2 millimeters in. So you just double the number and put it in millimeters. That's how far you're pressing in to be able to grade that edema. And look for varicose veins. So here is the picture of, for 1+, it's 2 millimeters in, 2+, 4 millimeters, 3+, 6, 4+, 8 millimeters. Infants, you want to look and palpate the brachial, radial, and femoral pulses. Use upper arm or thigh for blood pressure measurements, and evaluate the capillary refill, and prolong as longer than 2 seconds, as it is in the adult. Children, realize that a venous hum is common and has no pathological significance, and this happens often with a Still's murmur. It can be caused by the turbulence in the blood flow in the internal jugular veins. And so if there's a venous hum, that is a benign finding. Blood pressure is easy to measure in kids older than 2 years. And use the correct cuff size, which covers 2/3 of the distance between the elbow and the shoulder. Blood pressure varies with gender, and it's going to vary with height. So here you're auscultating for a venous hum in the carotids of a child. Hypertension in kids, 1 to 3% of the kids, and early detection is essential. So start checking at 2 years old. Hypertension often is caused by kidney disease, renal disease, coarctation of the aorta, or pseudochromocytoma. So these are the things you really want to rule out. venous thrombosis is less common in kids. Coarctation of the aorta, you realize that you've got the aorta here has got the problems, and with it, they just went ahead and cut the aorta, cut this out, so you can realize coarctation of the aorta is just a thinning or a pinching of the aorta, and this will increase the blood pressure. So they're going to have to straighten out that coarctation, take out this V. Pregnant women, blood pressure gradually falls until 16 to 20 weeks, then gradually rises to pre-pregnant levels. Sustained systolic blood pressure greater than 140 or diastolic greater than 90 may indicate pregnancy-induced hypertension. Older adults, dorsal pedalis and posterior tibial pulses tend to be more difficult to find, especially in the obese. There is a loss of vessel elasticity can cause increased intracranial pressure, and the hypertension in older patients is pressure greater than 140/90. So abnormalities. Temporal arthritis. This is one you need to know. It's an inflammatory disease of the branches of the aortic arch, including the temporal arteries. And when you press over your temporal areas, you'll feel the pulsation, but these people will have, on temporal arthritis, pain when you palpate. And normally there shouldn't be pain. And you really want to get onto this, and they hit them with high steroids just because it can lead to blindness. So temporal arthritis is something you need to know. It's the same as giant cell arthritis. Arterial aneurysm is a localized dilatation, generally 1.5 times the diameter of the normal artery, and it's caused by weakness in the arterial wall. And you might have an arterial venous fistula as a pathologic communication between an artery and a vein. So here's the normal. You see the dilated or stretched intima on the right. You can have peripheral arterial disease, stenosis of the blood supply to the arteries by atherosclerotic plaques. Raynaud's phenomenon is exaggerated spasms of the digital arterioles, which are the very small arteries, and usually in response to cold exposure. It can also be in the nose and the ears. Raynaud's phenomenon is more common in people that are raised in colder climates, like up in the north. And the treatment is move to the south. You've got to stay away from these cold exposures and wear gloves. Arterial embolytic disease. And this is arterial fibrillation that can cause a clot within the atrium. And what this will do is then the clot will be shot out from the heart and dispersed throughout the arterial system, landing most often in the brain or the lungs. And then if it lands in the brain, you've got a stroke, and if it lands in the lungs, you've got a pulmonary emboli, and neither one is good. Embolotic phenomenon is where you've got different blood clots that are shooting out to the peripheries. And here's a picture of embolotic phenomenon where she's just shot a lot of clots, or he has shot a lot of clots. Raynaud's phenomenon, here's a picture, and you'll just notice that they end up with discoloration of their fingertips and very cold fingertips often. Raynaud's phenomenon, and it's one of those diseases that responds well to calcium channel blockers. Vessel disorders, venous thrombosis is sudden or gradual. It can be either sudden or gradual with variations of the severity of the symptoms. It can result from trauma or prolonged immobilization. And when you say prolonged immobilization, that can be as short as 3 days. So this is why everyone will go ahead, if they're in the bed for longer than 2 days, or start some kind of low molecular heparin or Levinox, that kind of thing. Hypertension, one of the most common diseases in the world. It puts you at risk for stroke, renal failure, and congestive heart failure. And tricuspid regurgitation is the backflow of blood in the right atrium during systole. Atrial fibrillation is arrhythmia seen more commonly in older adults, resulting in decreased cardiac output and atrial thrombus formation with subsequent embolization or blood clots. Cardiac tamponade is the accumulation of fluid within the pericardial space, leading in the compression of the heart and dysfunction in the cardiac chambers because they cannot adequately fill. Constrictive pericarditis is results from chronic inflammation and subsequent scarring of the pericardium. Coarctation of the aorta is where you're going to have a pinching or a narrowing of the aorta. And Kawasaki disease is acute vasculitis, disease of uncertain etiology. It affects young males more often than females, and its critical concern is cardiac involvement, which aneurysms of the coronary artery can develop. And this is one where the tongue also turns cherry red, very red, and has spots on it, kind of like a strawberry. Pregnant women, preeclampsia and eclampsia. It's syndrome just specific to pregnancy, determined by hypertension that occurs after 20 weeks of pregnancy, and it has the presence of proteinuria. Eclampsia is preeclampsia with seizures when no other cause for seizures can be found. Older adults have venous ulcers from venous insufficiency in the lower extremities, and here is an example of a chronic venous insufficiency, and it will bleed and there can be an ulceration there. Thank you, and this is the end.